Welcome to the RSNA Radiographics podcast. I'm your host, Dr. Jonathan Revels from New York University. On today's podcast, I'll be discussing one of our latest chest articles from the Radiographics Fundamentals Classic Signs on Chest Radiographs, Primer for Residents by Dr. Ufuk and colleagues. The chest radiograph is an essential diagnostic tool in medicine because it can provide a rapid assessment of cardiac and pulmonary conditions. Now, being able to correctly interpret chest radiographs truly hinges on a radiologist's ability to not only understand the technique and normal chest anatomy, but also on your ability to appropriately correlate the study to prior exams, history, and potentially recognize the various classic chest radiograph signs. Chest radiograph signs are important to know and recognize, not just because they can be associated with pathologies like cancers and pneumothoraces, but also because they can help you recognize normal anatomy and thereby prevent unnecessary interventions for patients. The authors of this article have really done a great job loading this manuscript and presentation with some truly awesome cases and teaching points. Today, I'm only going to be able to touch on some of these signs. So when you have a chance, head on over to the Radiographics website and you can check out the full manuscript and presentation. Now let's start with a sign that is foundational when it comes to learning how to interpret radiographs, and that's the silhouette sign. On chest radiographs, structures that contact or closely oppose one another will obscure each other's borders when they have a similar radiographic density, and this is called silhouetting. The silhouette sign is observed when the normal silhouette or the borders of a normal structure are lost, and this can be due to pathologies like a mass, consolidation, or a fluid collection. This sign is crucial for localizing the finding, which can then aid in formulating your differential. Now, a great example of how we use the silhouette sign in teaching chest radiographs is when it comes to right lower lung opacities and determining if the finding is in the right lower lobe or the right middle lobe on a frontal chest radiograph. A right middle lobe process will obscure the right heart border, whereas a lower lobe process can obscure the hemidiaphragm but maintain that right heart border. Now, obviously, this example is an oversimplification since multilobar processes are common, but I think you get the overall idea. So next is the spine sign, which is also known as the more black sign. This is a valuable radiologic sign because it can help detect and localize lung opacities on a lateral radiograph. Now, typically on the lateral chest radiograph, the thoracic spine will appear progressively darker as you move from the top to the bottom of the chest. And that's because inferiorly, you have an increased quantity of air filled lung tissue. But when there's an abnormality present, such as consolidation, atelectasis, or a tumor, the involved lung will appear denser or more radiopaque. So when it's at the lower aspect of the chest, you're going to lose that expected lucency. Now, let's switch gears and review some signs associated with pneumothorax and pneumomediastinum. First is the deep sulcus sign. Now, this is typically observed on a supine chest radiograph, and it indicates the presence of a pneumothorax. This sign describes a deepened and sharply defined costophrenic angle when the patient's in a supine position, and that's occurring because air in the pleural space is accumulating in the anteromedial aspect of the pleura, and it's going to then push down on that diaphragmatic pleura and thereby deepening the costophrenic angle. Next is the continuous diaphragm sign. Now, normally on an anterior chest radiograph, the central portion of the diaphragm is going to be obscured by the heart and other mediastinal structures. When air accumulates in the mediastinum, pericardium, or peritoneum, meaning the patient has pneumomediastinum, pneumopericardium, or pneumoperitoneum, respectively, you may see a continuous lucency now along the diaphragm. And this is going to be characteristic of the continuous diaphragm sign. So you'll want to make sure you can understand or figure out why it is present, whether it's postoperative or not, and maybe contact the clinical team to launch further clinical or radiologic investigation. The last sign for this section that we're going to talk about is the ring around the artery sign. Now, the ring around the artery sign is a lateral chest radiograph finding that refers to a semicircular radiolucency that's going to be surrounding the right pulmonary artery. This is caused by pneuma mediastinum, and it can help distinguish this entity from something like pneumopericardium. Now, lastly, let's discuss some chest radiograph signs that are associated with the cardiovasculature. First up is the heart. I want to talk about the double density sign. This is also termed the double right heart border, and it represents a curvilinear density that can be seen projecting over the right retrocardiac area. And this can be observed due to left atrial enlargement. Now, on a frontal chest radiograph, the left atrium normally is going to lie behind the main cardiac silhouette, so it's not really going to be appreciated. But when it enlarges, it impinges or encroaches on the space that's normally occupied by just the right atrium. And as a result, you get two densities at the right heart border. It's important to remember, though, that this sign has a differential, and that includes left atrial enlargement, ascending aortic aneurysm or dilation, cardiac tumors, hiatal hernia, and even mediastinal masses. Next is the Oreo cookie sign. And this is a lateral chest radiograph descriptor that is associated with a pericardial effusion. This sign visually depicts the pericardial effusion as a dense, centrally located opacity resembling the cream fill component of an Oreo cookie that's then going to be bordered anteriorly and posteriorly by dark areas of pericardial and epicardial fat, and those are going to represent that yummy chocolate cookie. Now, let's review some of the signs that have associations with pulmonary embolism. First is the Hampton hump sign. This is seen on frontal chest radiographs, and it refers to a triangular shaped peripheral lung opacity that has an apex pointing towards the hilum. It's typically associated with pulmonary infarction, which is often secondary to pulmonary embolism. The differential, though, for this finding includes pulmonary embolism with infarction, pulmonary infarction from other causes like sickle cell disease or even vasculitis, but you should also consider entities like organizing pneumonia and even infectious pneumonia. Next is the Westermarck sign. Now, this sign refers to an area of focal oligemia, meaning you have decreased vascularity and thus decreased blood flow to that part of the lung. And it can occur distal to a pulmonary embolism. The Westermarck sign is thought to be caused by dilation of the pulmonary vessel proximal to the embolism and then collapse or vasoconstriction that's occurring distal to the embolism. There is still a differential here. So you're going to think of things like pulmonary embolism, maybe even pulmonary artery hypoplasia or agenesis, and even pulmonary artery aneurysm. Lastly is the Fleischner sign. The Fleischner sign characterizes enlargement of the central pulmonary artery, which in the acute phase is going to be due to a large embolus. But subsequently, in the subacute to chronic phases, that arterial enlargement is often attributed to increased pulmonary artery pressure. An ancillary finding of the Fleischner sign is going to be the abrupt tapering of the occluded pulmonary artery distally. And this can create another sign that's called the knuckle sign. The differential for this finding is going to include pulmonary embolism, obviously, pulmonary artery hypertension, and again, pulmonary artery aneurysm. Now, that's all the time that I have for the signs today. So I just wanted to thank Dr. Ufuk and colleagues for creating this amazing article and presentation. And thank you, our listeners, for tuning in. Make sure to rate, review, and subscribe to the RSNA Radiographics podcast. And check out the Radiographics website for more on the latest radiology educational content.